What was the problem? First of all, we had to use intubation. Right from the morning, we are telling you, please avoid putting endotracheal tube. But even if we are putting baby on CPAP, just for giving surfactant, we had to intubate the baby. So our whole aim of giving ventilation, non-invasive ventilation was defeated just because for a small procedure. The second problem was whenever we used to give surfactant, what do you do after giving surfactant in insure?
Extubation.
We used to do bag and mask. So what does bag and mask do? If you are a first year student, we have an MD in Bangladesh, right?
Yeah.
We have 3 years MD.
5 years.
5 years. So if he is day 1 MD, he will bag like this. If you are post duty, you are done your night duty, you will bag like this. Okay. If you have your breakfast, very good breakfast, chicken and all, again giving lot of pressure. And if you are hungry, you will just wait for your reliever and somehow just do the bag. So there are lots of variation in the pressure. And in the morning we discussed that there are 5 types of lung injury, and one of them was barotrauma. Usually a neonate requires pressures from around 20 to 25, but we can give as high as 50 to 80 depending on how enthusiastic I am to bag. So this is again problem, and in animal studies we found that even if we give 5 breaths, mechanical breaths, they are sufficient to cause lung injury and BPD, that is chronic lung disease. Third problem was, we talked about CPAP. That is, we want to open the lung. We want to recruit the lung. But whenever we are intubating, what we do first? A baby is on CPAP. You need to give surfactant. First of all, you will take out the CPAP. So whatever recruitment, whatever lung you had opened up. So which form of injury is this? So you have caused barotrauma. Now you are causing atelectotrauma. What does atelectotrauma do? Whatever little surfactant is there, the surfaces will rub against each other, so that little surfactant will also get inactivated. Plus it will cause lung inflammation, that will lead to lot of fluid into the lungs. So again lung injury. So in order to overcome this, we talked about being non-invasive even in giving surfactant. So that's why LISA came up. So, but remember that in LISA we have to use a catheter which occupies less than 10 centimeter, less than 10% of the diameter. In insure we put a tube which totally occupies the larynx. But in giving LISA, it may be a 5 French feeding tube, it may be a suction catheter, it may be even a cannula, like Vigon, 16 number. It should occupy only 10% of the circumference. Fine. Don't think that I can use 2 centimeter 80 tube, 2 mm 80 tube. I am giving LISA. That defeats the purpose. It should be as thin as possible, as small as possible, so that baby can breathe spontaneously. Whenever we put a 80 tube, the baby cannot breathe. The glottis does not close. Remember, the grunt is a protective mechanism. By doing grunt, what does the baby do? It maintains the FRC. It is the baby's own CPAP. Okay, so establish the FRC. But whenever we are putting it ET tube, baby is not able to breathe, and there is no adduction of the glottis. But whenever putting a thin catheter, the baby can still breathe, glottis can still close, and that automatic PEEP which God has provided all of us, including the babies, that is still preserved. Second thing is, I don't need to remove the CPAP. So whatever good I have achieved by putting early CPAP, that is still there.
Sir, one question. What is the ideal size for...
I will come, so you can let me finish, then I will take all your questions. So second important thing is, whatever FRC I have established, that is going to preserve. I am not taking CPAP off. Third important thing which we discussed there, no need of doing bag and mask. The other thing in insure was, after doing bag and mask, we used to connect baby to the ventilator. Now if I am the head of the department, I know Dr. Shaz is a first year, she doesn't know much ventilation. I will tell her, you keep this baby ventilated, tomorrow after rounds we will extubate. And so the duration is not limited. It may be half an hour for one unit, it may be 10 hours for my unit, it may be 24 hours for my unit. So baby can be ventilated anywhere from 30 minutes even to 2 to 3 days. If I am the only doctor working in my private setup and I have all doctors to manage, I will tell them you remain intubated, tomorrow I will only extubate. So there is a huge difference in duration of ventilation. Although we call it a brief, but how brief, nobody knows. So again in LISA, there is no need of bag and mask and no need of putting the baby on ventilator. And plus, whenever the baby breathes spontaneously, the surfactant which we give, the distribution is better. Clear? Somebody else asked the question.
What is the actual size for injection?
As small as possible.
Yes.
As small as possible. Usually, if you are using an NG2, 5 to 6, not more than 6. Fine?
At least 10%, less than
Yeah,
at least 10%, less than 10%.
No, I did not mention. I did not talk about LISA only. No, that was one of the studies which used it. It is not recommendation. You may be doing study with the 82. That doesn't mean you are doing it correctly. They did with 8 French too, but that is not the correct size.
But like how long are you going to this?
Excellent. Now I will come to the procedure. Now science is known. Now, so we have talked about the science of LISA. Now we'll talk about the art of the LISA. So first of all, asepsis, hand wash is most important. Fine. This baby is on CPAP. When should we consider giving surfactant? Whenever it is more than 30%, and I am sure that this is RDS. This is not anything else. Fine. So now we have decided that we give surfactant. Best is to give within 2 hours of life. Sooner the better. Because once the lung has collapsed, atelectasis has happened, it will be less effective. That is not, it will not be effective, but that effectiveness will be less. Plus, whenever in the initial 2 hours of life, some amount of the water is still there in the lungs, which keeps the lung open. Fine. So for this, ma'am asked about the depth, how much depth. So just like intubating, we calculate NTL, that is from septum
To tragus.
to tragus plus 1. So that is the same. How I will do? First of all, I will do a proper hand wash, wear a cap, wear a mask. So septum, nasal septum to tragus plus 1. So now suppose my NTL is 9. So how much I have to insert?
10.
10 centimeter. Now you will tell me this is very soft. Now before doing that, you put this in the freezer. Freezer. Refrigerator level. उसके freezer में for half an hour. This will become stiff. So now I know that NTL is 9 centimeters. How much I have to insert?
10.
10 centimeters. Now I will ask one of my friends. He is taking inch tape. Usually we have inch tape for each bed. Right? So now I know that I have inserted 10 centimeters. Right? So first of all, majority of the OG tubes, they are very long. We don't need this much long. If it is long, it will be very difficult to do. So what I will do, usually I will cut it into half. So now, what is this? No, I know that this I have to 10 centimeters. So that centimeter will be from the bottom. I will ask. Usually in our country, our OG tubes comes with the marking. But if you have a OG without marking, I will ask my colleague to put a mark. Fine. So I have a mark here. Now what I will do, just like intubation, I will do all stuff like wash my hands, then put a gloves, cap, and before this, if the baby is on CPAP, I will increase the CPAP pressure by 1 to 2 centimeters. Why? Because now I am opening the mouth, so there will be a drop of the pressure. To overcome that drop in the pressure, I will increase by 1 to 2 centimeters. Fine. So, and we will pre-medicate. Do you use intubation for intubation? Do you select intubation or pre-medication?
We don't use.
All intubation should be pre-medicated unless it is life-saving, that is emergency. Surfactant is an elective intubation. So you should use atropine and fentanyl. That will take, because whenever I am putting a limescope, it touches the posterior pharyngeal wall. What is there? Which nerve is there? Vagus nerve. It will lead to bradycardia, apnea. That is not because of your LISA. That is because of the stimulation of the posterior pharyngeal wall and the larynx. Once you use atropine, you are taking care of stimulation of the vagus nerve. Atropine is vagolytic. And second thing is, whenever I am putting this, it will cause some pain, it will cause some discomfort. That will lead to IVH. So that I will use fentanyl. So once I put this, I will visualize the larynx. Okay, once I have visualized the larynx, I will ask my colleague to give this OG2 and then I will put it. Fine. And once it has just 1 centimeter beyond glottis. One thing is how much to insert.
1 centimeter beyond.
Yeah. This is the mark. To begin with, you should go with the mark only.
This mark should be.
Once in visualization I put it in the larynx, I should not keep it there. But if you are doing it initially, you should keep it there. Otherwise, you may be giving surfactant. It is a costly drug. You may be giving it in the stomach. Since I have been using it for more than 10 years, I am confident of the procedure. As soon as I put OG across the glottis, I take it out. Fine. So I know the mark is there. So I will fix it just like 82 and ask my friend to give it the surfactant. Depending on which surfactant you are using, if the volume is less, you can give it in 1 to 2 electrodes. If it is over 5 ml, you can give it in multiple electrodes or continuously as a bolus. Remember, whenever you are doing this procedure, one of the team members should always be looking at the saturation and heart rate and give it over 1 to 3 minutes. If there are no desaturation, no bradycardia, you can give it continuously in 1 go. Whenever the saturation starts dipping or there is bradycardia, stop. Majority of the time, baby will recover of its own. Right? And remember, there is always a CPAP in place. Very rarely you may have to use an IVPV. This is CPAP, connect to the ventilator. If baby is not recovering, taking more time, shift to an IVPV. Fine? And once we have given, give 1 to 2 ml of air because there will be some surfactant left in the tube. So push that surfactant into the lungs. Once it is put, take it out. And once you have given the surfactant, the head should be elevated 15 to 30 degrees to prevent the reflux. And wait for 5 to 10 minutes and bring the pressure back to
Baseline.
previous levels because now the mouth is
Closed.
Because if I do previously, I will not be able to intubate. As soon as I have given the surfactant, I'll wait the head. Bedded should be able to intubate.
So should we remove the OG tube that is placed previously when the baby is on CPAP?
Whenever there is any baby or any form of oxygen, should always have OG tube in place.
Okay, sir.
And that should be open 15 minutes after the feeding. So that whatever gas goes into the stomach, that comes off. This is a separate OG tube. Once we have given surfactant, it should be removed as soon as possible. Clear?
So how?
Freezing is enough to rigid the catheter to introduce into
For
the.
beginners, you should keep the laryngoscope there so you can see directly the surfactant going into the trachea. The other important thing or other aid which can help you is using a video laryngoscope.
That the measurement is 10 centimeters and introduce 1 centimeter
Nasal mark, NTL plus 1.
স্যার আমরা যেটা
from glottis to 1 centimeter.
স্যার
Either you can use either.
we use the ventilator's ET tube size weight plus 6.
No, that is not. Now NTL plus 1 is more effective. It is more accurate. So anybody wants to practice?
Another question, 10 centimeters from here to here.
No. Below to above. Because this is the length which will go inside.
And
So
what
it has
about
to, it can be vary. It can be 10, 20. It doesn't matter.
We should
But
be
smaller the better because then handling becomes easy. If it is too long, you cannot manipulate.
So what should
can
be
I
the maximum?
maybe can we take this?
Sir, what should be the maximum duration?
When it continuously, if there is no desaturation,
Excuse me, that 10 centimeter marking. Suppose the 10 centimeter marking should be in the angle of the mouth.
No.
No.